Every physician has a moment in their career where the diagnosis arrives like a verdict, where the lab result on the paper in their hands explains everything and makes everything worse simultaneously. For the team treating JC, our Massachusetts student, that moment came when the cultures came back. For the team in Brussels, it came too late. For the team in Australia, whole genome sequencing would eventually confirm what the food testing already suggested. The question was never only, what is this organism? The question was, how do we catch it in time? And how do we treat it without making it worse? When a patient presents with rapid onset vomiting, abdominal pain, and, in severe cases, organ failure after consuming rice or pasta leftovers, the clinical investigator becomes a detective. The first move: blood cultures. In invasive disease, Bacillus cereus bacteremia can be confirmed from blood. Gram-positive rods in blood culture bottles, large, square-ended rods, should immediately raise the index of suspicion. On screen, Bacillus cereus on blood agar, large, flat, irregular, beta-hemolytic colonies after 14 to 24 hours. Malditov confirms ID in minutes. Stool cultures on selective media, specifically MYP agar, which stands for mannitol egg yolk polymyxin, allow selective isolation of Bacillus cereus from gastrointestinal specimens. The lecithinase activity creates a distinctive opacity halo around colonies. But here's the move that changes everything. Submit the food. In the Australian case, investigators located the remaining rice and inoculated it onto blood agar, then performed ethanol shock treatment. This is a technique that selects specifically for spore-forming organisms by killing everything else. After 14 hours of incubation, large beta-hemolytic colonies appeared. Malditov returned a Bacillus cereus score of 2.43, high confidence identification. For the gold standard, liquid chromatography tandem mass spectrometry, LCMS-MS, can quantify cereulide toxin directly in food. In the Belgian pasta case, this revealed 14.8 micrograms per gram. The pasta was carrying nearly 1,500 times that minimum threshold. On screen, diagnostic sequence, blood culture, stool culture, food specimen, Malditov ID, WGS toxin gene confirmation, LCMS-MS cereulide quantification. Now comes the part where clinical knowledge can mean the difference between a patient who survives and one who does not. Because here is what most practitioners never expect. The obvious antibiotic choice will fail. Bacillus cereus produces beta-lactamase. That means it is intrinsically, constitutively resistant to penicillins, amoxicillin, ampicillin, and to all generations of cephalosporins. If you empirically reach for a first-generation cephalosporin, you have lost time. The correct empiric choice for serious Bacillus cereus infection is vancomycin. All major studies confirm universal susceptibility, no resistant isolates found across thousands of clinical specimens. For bacteremia, clinical evidence supports adding gentamicin, an aminoglycoside, to achieve faster clearance. The dosing for invasive disease, 15 to 20 milligrams per kilogram IV every 8 to 12 hours. For invasive infections where vancomycin cannot be used, ciprofloxacin and levofloxacin show consistently low resistance. Linezolid and daptomycin are options. Clindamycin is not a reliable empiric choice. For emetic syndrome presentations, where cereulide is the primary culprit, the toxin is preformed, and antibiotics cannot remove it. Treatment is supportive, aggressive IV fluids, management of metabolic acidosis, dialysis, and ventilation when required. We have walked through 3 case files. We have profiled the organism. We have followed the evidence from the takeout container to the ICU. Now we come to the part that matters most. 5 rules. Commit them. Rule 1. Refrigerate cooked rice within 1 hour. Not when it cools. Now. Divide into small, shallow containers. Rapid chilling is the goal. Spores begin germinating between 40 and 140 degrees Fahrenheit. Do not help them. Rule 2. 2 hours is the absolute maximum time cooked rice can spend at room temperature. 1 hour if the room is above 90 degrees. The bacterium does not need a week. It needs an opportunity. Rule 3. Refrigerated rice. Consume within 24 to 48 hours. These are not overcautious suggestions. There is no sensory warning. There is no smell, taste, or visible contamination. The only warning is this video. Rule 4. Reheating kills bacteria. It does not deactivate cereulide. If the toxin has formed in your food, boiling it, microwaving it, or putting it in a 400-degree oven will not make it safe. The toxin is stable. Rule 5. When in doubt, throw it out. No leftovers cost what JC paid. Resist the takeout container that sat in a warm car for 3 hours. The cost of a takeout container is not worth what it might cost you. Bacillus cereus will not appear in your nightmares the way Ebola does. It is not dramatic until it is. But in the cases we have examined, it revealed something clinical and cold: the capacity for total, irreversible destruction. The mechanism is elegant and pitiless: a heat-stable toxin pre-formed in your food before you ever touch the reheating button, quietly waiting. It does not discriminate. It will not smell off. It will not taste wrong. And by the time the purple skin appears, and the neck goes stiff, and the blood pressure crashes, the fight is already in its last rounds. The best treatment, in medicine, as in most things, is never needing one. Refrigerate your rice. Do it quickly. Do it now. Like and share to support our content. Visit unbedsidemanners.com for more medical mysteries like this.